Okay, welcome everyone to our ACME stakeholders meeting. Today, we're going to have experts talk about the difference between BRFs or behavioral health residential facilities and ALTECs, Arizona Long-Term Care System. Um, we're really privileged to have experts from Mercy Care. So we have Blythe here. We have Elizabeth Forsythe, who's nationally certified counselor, licensed professional counselor in Arizona and Colorado. Graduated magna cum laude from Arizona State University, Go Devils, with a bachelor of degree in psychology, with honors from the University of Phoenix with a master's of science in clinical mental health counseling. She's got a lot of experience working at Florence Crittenton and as a therapist at St. Luke's Behavioral Health Center, along with working in intensive outpatient chemical dependency programs and also on the inpatient units for court-ordered treatment, uh, primarily treating members designated as SMI. She works for Mercy Care as an associate manager in clinical health services, supervising adult behavioral health residential team, which oversees the BERFs, the adult behavioral health therapeutic homes. That's a new one, ABHTH. Substance use disorder residential, SUDRs, transitional living placement, TLPs. She's also adjunct faculty at Grand Canyon, and it can go on and on and on. I think it was in, so a very impressive resume. And then we also have Daniel Johnson, who's worked at Mercy Care for 6 years as a clinical manager within the utilization department, overseeing a team of utilization management nurses. He primarily works with pediatric members and members admitted on a skilled day at a skilled nursing facility. Daniel is a registered nurse with 11 years of experience in hospitals, predominantly emergency rooms, where he received his emergency nurse certification. And then we have Cindy Leach, who's been the vice president of long-term care at Mercy Care since December 2020, bringing 35 years of experience in healthcare administration, financial management, executive leadership, program development. With her to these roles, she's responsible to develop, implement, oversee, and evaluate Mercy Care's ALTEC. She ensures appropriate and cost-effective medical and medically related social and behavioral services and supports are identified, planned, obtained, and monitored for eligible ALTEC services, families, caregivers. In addition, she develops connections and partnerships with workforce development, community-based services. And before Mercy Care, she was owner-operator officer at Copper Sands, a senior healthcare management company. And the reason why we thought this is so important, so many family members see their loved ones that have an SMI diagnosis as they age. And it gets to the point where sometimes their medical needs are trumping their behavioral health needs. And then it's very difficult, we found, to try to get them qualified on ALTECs and also to have some of the medically necessary services while they're in a birth. So welcome. And Blythe, if you want to kick it off and if you want to share.
Yeah, so great to see you all. I'm going to pass it over to the Mercy Care team. I'm going to get their presentation up. Let me know if you can see it.
Yes.
Okay, great. It's tough when you have multiple screens. So I'm going to mute myself and then I will pass it over to Cindy Leach.
Hey, good afternoon, everyone, and nice seeing you, Lori. I know it's been since the governance committee on that, so I appreciate the invite to talk a little bit about what the Arizona long-term care system looks like. And as you read there, and please, my name, I know that all my titles say Cynthia, but I am Cindy. So if anybody has any questions or anything, please let me know. So I thought first we would start with screening, like you had there, Blythe. of what that eligibility and screening process is initially for the All-Tex program. And when you talk about needs and services and people needing more hands-on care, to be eligible for All-Tex, you must be at a nursing home level of care, and that is determined by Access. They do the initial review and assessment for people that are interested in getting into the All-Tex program. But let me first start off and say that one of our goals is that members are in the most integrated and least restrictive environment. So it may seem that people need to be in the nursing home, but as of today, only 25% of our members are in nursing homes, 75% of our members are in assisted living, and or they still do live at home. Of course, then people are to be citizen or qualified immigrant, Social Security, be an Arizona resident, but also apply when they do the application process, also to bring in any other cash benefits that they may have, any pensions or VA. And then also to have an approved living arrangement, which would be including if they are in their own home, or as I said earlier, with a nursing home and or assisted living facilities for there. It is a process, and we do work with a company that we provide to help members with an All-Tex application, because the All-Tex application can be a horrendous process to go through, and not only just the piece of the income, but definitely the physical needs. So I thought I would share with you what is called the uniform assessment tool. Access uses this tool when determining if a person qualifies for All-Tex or not. And in the All-Tex program, whenever a person joins, they are assigned a case manager, and then case managers also do ongoing assessments. And so we utilize this uniform assessment tool. You may hear it referenced as a UAT, but this has been used by Access for more than 30 years now, and they use it for not only people that are in assisted living, but also for people that live in the nursing home. But what I know it's small writing, and I apologize for that, but I wanted you to see this tool because if you can see, and I will explain it to you, under the first category there is a class 1. Access determines what level of care that people come in initially, and then the assigned case manager works with the member, works with the family to ensure that they are under either a class 1, a class 2, or a class 3. And so you start off with a class 1. The member has to have 3 or more of the following, and that is when we get into that physical care, Lori, that you were mentioning, and I know that people are interested in, to know what are their needs for bathing, dressing, or grooming. Do they need assistance, or are they independent with feeding and eating? How is their mobility? Are they able to ambulate by themselves? Do they need assistance in transferring from one location to another? Also, are there any interventions that are required for bowel or bladder incontinency? But then there is a component about orientation and behavior where there's either intervention that needs to be with a member, or maybe no intervention. Is it continuous? Is it maximum interventions? But also their medical condition and any treatments that they might be receiving. So if somebody meets at least 3 of the following there, then they do qualify to be in the All-Tex program. So I hope that that helps in explaining a little bit of how that process goes. Next slide, Mike. Thank you. Income guidelines, and I'm sorry, Lori, I see your hands up.
Oh, I just was wondering, If people have questions, do you want them to save it to the end, or do you want them to ask it in chat, or do you want them to raise their hand?
I, if Blythe can help me monitor the chat, then we can do during the presentation. I know sometimes it's better to catch it as I'm talking about specific ones. So that's great. So does anybody have any questions?
I have a question.
Yes.
And the question is, I had always thought that if you have a diagnosis of Alzheimer's, you need no other medical conditions, psychiatric conditions, and would be qualified for Altex.
That would be part, there's still an assessment process that is to be completed, because you can have a diagnosis of Alzheimer's, but you may not have any physical needs and could still be functioning. So I have worked with people that have had diagnosis of dementia and Alzheimer's, but if they're very early stages, then there's no physical needs that they may require. It's as they progress in that. Does that help?
Yeah, it does.
Okay, great. Thought I'd put in this Altex income guidelines because it is a financial, as we know, in working with access and also with the physical abilities. And so this is the gross income limit that is counted. But again, it's not limited to being married, or if their income is over limit. I know that multiple people will qualify in setting up special types of trust, like a Miller's trust. And then if anybody is going through the process, ask for a special treatment trust information sheet. And again, we do work with a company that we actually provide the services to be able to assist people to ask for assistance in that Altex application when it comes to the financial and physical. So once a member is determined to be eligible, they are enrolled with a program contractor. And as of today, there are 3 program contractors, and that is Mercy Care and also United Health and also Banners. And that is in Maricopa. And then there is one up in northern Arizona, which is United. And then in southern Arizona, it is Banner, while Pima County has 2 program contractors, and that is Mercy Care and also Banner. I had mentioned before that member is assigned to a case manager, and that case manager is tied to that member continuously and working and developing person-centered service plans and just getting the needs of what the member is looking for. And we'll meet with the member and develop, and I already mentioned that person-centered service plan. So any covered services can be included, not limited to I already talked about the nursing home and community-based services. And when home community-based services are mentioned, that is those that live at home, but also those that live in assisted living. And there is also outpatient and in-home care, medical services, behavioral health services. So there are opportunities for members seeking or needing behavioral health services. That can also be done through the Altex services. And then we also have children and then hospice services. Some people are surprised to know that with Altex, our youngest member is 6 months old and our oldest member is 104. So we have a wide range of people that need physical and behavioral health care. Yes, Lori.
Okay, so if a person, since you want to keep people out of skilled nursing facilities as long as possible, if, let's say, for example, the person is living in a somewhat supervised home in the community or a birth, but they now qualify for all techs, would they stay in the BRF and then you would bring the services to them, or would they have to move? Where would they move to since they don't have a place of their own?
So we do have members that are in births that do need some care, and we do have some that do provide some hands-on care, but we also have assisted livings that do specialized programming for people that might have behaviors that a typical assisted living would not want to have in their assisted living home or center for that. So there are options. Once somebody qualifies for all techs, there are options for placement to go into an assisted living or a behavioral health residential facility, and it is based on what their physical needs are.
And if they get an assessment, like say today, and it was a really good day for them, and they score really low and they don't get on, is there a waiting period before you can ask for another assessment?
Um, I think there is, Lori, but to be honest, I can't give that to you right now, but I'll find out and get that information. So once assessment, because that's the access process. And I'm writing that down so I don't forget.
I wrote it down too, Cindy.
Oh, thank you.
Yeah.
Hey guys, you keep saying the word BRF. Can you explain that abbreviation for everybody? Because I think some don't know it. BRF.
It's behavioral health residential facility. And we have
Thank
some
you.
additional information on the BRF. Sure, Rachel.
Okay. Next slide there, Blaine. So also what people do not realize is that all long-term care members, including SMI members, whether they are designated or not, they're entitled to all medically necessary behavioral services. And so there is a list here so that, again, members coming from a behavioral health residential facility, they are all techs. They receive all tech services. They are getting a lot of the same services that they would in a behavioral health. We do have members that continue to be in a behavioral health residential facility, but if they're in assisted living or they're in a home or in a nursing home, they do qualify for all of this. The one difference that you'll see though is once somebody rolls all techs, it's more of a housing service. And so that's why sometimes there's a change when people roll over to all techs, because then there have to be a room and board that occurs there. And I know that some people that roll over sometimes do not realize that they are paying for the housing and the services of living in a long-term care setting. Yes, Rachel.
I have a quick question. So I understand that if someone is in an all techs assisted living home, that's their home permanently. And if they go to the hospital or go have a procedure, have to go inpatient for a minute, their bed is saved. Well, BHRFs, you lose that bed after 3 days. That's not their home. So how is that resolved if someone qualifies for and is receiving all tech services, but is still in the BHRF? Did that make sense? My question?
It does make sense, Rachel. When a member is in an assisted living and they have paid for their room and board, the assisted living may or may not hold that bed, depending on how they want to, even though it's considered their home. And that is the same for a nursing facility. So it's not an automatic that bed or that room will be held, even though it is their home. It would depend on the assisted living and or the nursing home that they're staying at if they are going to.
So where does the patient go after they are ready to be discharged from the hospital?
Again, that would be based on whatever the discharge planning is. If they, it really does depend on the assisted living. If we're talking assisted living, if they will hold the bed or not. Sometimes the assisted living, if they'll work with the member and work with families and have the ability to hold that bed, or sometimes assisted livings will ask if the member or the family can pay private pay for that bed until the member comes back into the assisted living.
And I would imagine, Cindy, that this is some of the nuances that would happen in regards to like clinical staffing, talking about treatment planning, discharge planning, with involved family members, the member, and the case manager, as well as the facility.
Absolutely. Working all together to try and get them back to the same place.
Now, births are not considered long-term living arrangements. So how does, if somebody's in a birth and receiving Altec services at the birth, then the residence in the birth is considered short-term. Would the answer to where they go next be the same as what you just described for when they are ready to come out of a hospital?
That birth would be up, they would again be able to, yes, it'd be part of that discharge planning and working with the case manager and the member to get them back. We always want them to go back to the same setting. So it would be the same description as going back into a birth.
Do you provide services for people who in community living programs as opposed to birth?
I'm sorry, I missed that.
So it's the community living. So Dick, you're talking about somebody that, like, let's say that an adult has an SMI designation, maybe they're determined that they qualify for Altex. So in a community living, they sign a lease, and then there can be staff that are providing support to them through behavioral health services.
So would Altec provide services, kind of home services for that person in the community living environment?
Is that, are you talking about in their home when you're saying community living?
Yes.
Then they would get the same services that were going on if they were living at home. Those would continue.
Okay.
Yeah, and Elizabeth and Daniel are going to talk a little later, a little bit about some of the nuances of the difference between skilled nursing, BHRF, that gets to some of those questions of how do those facilities maybe look differently and or what do they offer. But that's what I was imagining, what you were getting at, Dick, like from that scenario.
Right.
That's it. Yeah, thank you.
And then the Altex members who do have an SMI designation, they also get these following services that you see on here in regards to substance abuse, so supported housing, special assistance, mental health, childcare, the room and board that I mentioned earlier, and traditional healing. So. Okay. And then placement, I mentioned before the assisted living facilities. As far as people that may need help with dressing, bathing, eating, and toileting. And then the placement for the BHRS here is providing that treatment. And that is the difference between a BHRF is they are able to provide, the staff that is in there is able to provide treatment. In an assisted living facility, any treatment that would be needed would come in from somebody that's coming into the assisted living and actually doing the treatment. The people that are in the assisted living, the employees there, they are doing the hands-on care. They know how to communicate and work with people, but they're not allowed to be providing treatment. That would be based by somebody that actually comes in. And usually assisted livings will contract to be able to provide that services, though. So Daniel, are you on next?
Hi, thanks for having me. Kind of as it was mentioned before, I work on the UM side. So my team reviews and follows members when they're admitted in an acute setting. So that includes hospital. I've got reviewers that are following members in a SNF when they're getting acute care, and then members in long-term care hospitals or acute rehabs. But I wanted to kind of highlight a little bit of the process that kind of occurs when a member is transitioning from these levels, and then just the available support that is available for members and families, and then also frequently occurring behind the scenes. So one of the main kind of questions that we get is when we begin to discuss and look at the idea of applying for Altex and moving a member onto this. We've at times had families or facilities that are concerned that by moving to Altex, they will lose access to their acute care benefits, or at least the amount of therapy treatment that they're currently getting. And we just want to highlight that the beauty of Altex is you keep those acute care benefits and you get the additional long-term care support and custodial care. So what that allows us to do is, just because you've now rolled to Altex doesn't mean that you're going to see a reduction in whatever services you've been receiving. That can continue. So we've got a member that's in the hospital, they're in there for pneumonia. We're going to have a reviewer, a nurse, that's following that entire hospitalization, that's in contact with the hospital case managers, social workers, making sure that this member is progressing, that they're getting the proper care while they're in the hospital, and that a discharge plan is being worked on that's feasible. In that process, some of the discussions may begin about, is the proper line of business in place for this member? Are they going to need different benefits when they get out of here? Do they need different medical equipment? And we'll be assisting the hospital with getting that set up. Frequently, we'll see members that are not quite ready to go back to their previous living arrangement out of the hospital. And so they'll start in a SNF setting under skilled therapy. So maybe they need some additional physical therapy for a stretch. They need some wound care. They need some IV antibiotics. They're just not ready to go back to whatever setting they were in before. We'll assist with that transition and then begin to follow them and monitor that care that they're receiving now in that SNF. In that process too, frequently we'll be the ones that kind of start that conversation with the SNF of going, hey, I'm not sure this member is going to progress to the ability to go back home alone. And maybe this member is going to be needing some long-term care in the near future. Can we begin that application process? And so we'll begin to kind of work with them on that. One of the partnerships that we have that we're really proud of is Benefits Results. And this is an organization that we work with. Anytime we've got a member in these SNF settings or in a variety of different settings, we'll frequently refer them over to Benefits Results. We'll pull them in. And these are individuals that really understand Medicaid, all the ins and outs, the hurdles of getting onto Altex, the potential barriers, the different tips and tricks that can be done to help with that application process. They'll help monitor that application, keep us updates. And we've had a much higher success of getting members onto Altex in that first attempt, and also in just the expediency of that entire process. And so we will bring them in as early as possible to help with that and to help walk the family and the member through this. So they are really good at, okay, one barrier might be the finances. How do we get over that hurdle? Or maybe that first time you applied for Altex, you missed it by just a couple points. Well, they're really, really good at figuring out maybe the assessment wasn't done correct. Maybe we need a new assessment. Maybe we need a different doctor evaluation to help support this diagnosis or to highlight why Altex is appropriate. So we will frequently pull them in, and we've had families and members to ask that we pull them in too, which is always available. In the process of discharge planning, we're always assessing to see, hey, would a care manager, case manager be helpful for this family and member to help them once they're out of this acute setting? Not only will we be constantly screening for that and trying to get the appropriate care managers involved, but also members and families can always call in and request that a care manager is assigned as well. We've got our department and teams that are constantly assisting throughout that acute stay. And then a lot of times, like you guys were saying, we'll have members that are in settings that have both behavioral health needs and physical health needs. And it's a really complex discharge plan. We're not entirely sure what setting they might fit in or what benefit plan they may need. And we will frequently bring these type of situations and cases to SNF rounds or complex case rounds. So we'll bring in doctors with Mercy Care, we'll bring in care managers, we'll bring in people from all throughout the company that might have expertise, And we'll just try to dig through this case to go, how do we get this member the appropriate care and meet their needs? Additionally, too, we've got a transportation department that's available to help assist with getting these members transported to appointments that may be needed for these Altex applications. A lot of times it's a service that people aren't aware of that is covered through Mercy Care. And then the other thing, this is a really convoluted, complicated process. So you're stuck, you're not sure where to go. I mean, member services is the first spot there. Touch base with them, they'll pull in the appropriate parties, and there's a bunch of support that is available to try to navigate this very complicated system.
Hey, Daniel, you have Lori has her hand up. Hey, Lori, you have a question?
I was just going to mention that Jill Pulliam did a webinar last month, so she is great. She's great. Is an expert. And the second question I had was, or a question I had, if a member lives currently in a community home or lives in a BRF, and their medical conditions indicate that they could get on Altex because of their medical needs. If they get on Altex and they're living in a community home, can they keep their own psychiatrist and the team they're with, or do they switch to another case management team once they're on Altex?
At times, they may get a new care manager, case manager. That depends a little bit on what involvement they had beforehand. So that may change, but the providers shouldn't, for the most part. Every now and then there can be, one-off situations where maybe there's one provider that won't be able to continue, but for the most part, you should be able to keep your current treatment teams that you have.
Yeah, and Lori, I think one nuance, and Cindy, if you want to speak to that. So in Altex, case management is at the plan level. So case management as a service is not a covered outpatient service. So as you think about if you have a loved one that's getting outpatient services, they have an outpatient case manager, that there will be a transition there because case management is at the plan level. Access doesn't, it's not a qualified covered service.
And then
I think Rachel had a question too.
And as far as, and I can answer to that, as far as keeping the same SMI clinic, yes, as long as that contract is the same, if it's you're on Mercy Care, but now you're on the Altex program, we are contracted with the same, all the providers, so you would keep the same. And Lori, you mentioned Jill, so she's exactly who I was texting to ask about that waiting period. Sorry, Daniel, but since Lori brought it up, I'm throwing it out there. There is no waiting period. So once you're denied, you can start the process again.
Yeah, and Cindy, was that the question? I see Rachel in the chat about keeping your SMI clinic. So as Cindy mentioned, yes, that is something that we at Mercy Care have worked on to kind of have continuing of care. And then I see Dr. Churn is on from COPA and credentialing, but he made a comment there. And Elizabeth, you are up now.
Yes, thank you so much for having me. I will be discussing the behavioral health residential facility side when you are not on Altex. Primarily, this does impact our members who are SMI, although occasionally we may see a GMH member qualifying as well. But these are primarily SMI population. We have various settings in a BHRF. We have 5 main ones. The first one being a basic BHRF. You're meeting the standard criteria, which I will kind of go through in another slide. So if you do have a question, I hope to answer that in a moment. We also have a co-occurring BHRF for those who have current substance use and also the behavioral health diagnosis as well. So that they can not only work on their behavioral health, independent living skills and ADLs, but they can also work through any sort of sobriety journey as well during that. And something is popping up in the way, sorry. All right, and then we also have PCS, which stands for Personal Care Services. That's for our members who have the behavioral health diagnosis and need of a BHRF, but they might also have physical health care needs that require hands-on care. These facilities have specific licensure that allows them to provide PCS. So this isn't standard for every BHRF, and I will go through what can be offered in a PCS setting as well in terms of medical hands-on care. We have a 24-hour basic that's specific to eating disorders. So if your loved one has an eating disorder and they're discharging from an inpatient facility, we do have a step down into a residential that specifically will help them maintain the progress that they made inpatient and allow them the added care in this structured setting. And the last type of BHRF that we have is specific for polydipsia diagnosis. If you're not familiar with that, that's an increased intake in fluids, which can often be a concern for, diluting their medications, so they aren't as effective to keep them psychiatrically stable. So we have BHRF specifically designated where members don't have access to water outside of a shower or what's provided for them, so that they can help regulate that. And the next slide. So these are some of the standard expectations of a BHRF. First being that it is treatment, not housing, although I heard many of you say that earlier, so you're well aware of that fact. The average length of stay was intended to be 6 months. We do often see members who need longer than 6 months, but that is the average goal length of stay for the amount of time that members will take to achieve some of those more independent skills. This really is for members who require assistance with activities of daily living, which we call ADLs, independent living skills, which we refer to as ILSs, and of course their medications. Oftentimes they're not able to complete all of these independently and need more help to better learn these skills so they can be successful at a lower level of care. Discharge planning is always required upon admit. Sometimes people get a little nervous when their loved one just admitted into a BHRF and we're already talking about discharge planning. It's not saying that we want them to discharge anytime soon. It's just a requirement that Access has for any treatment level of care that discharge planning begin upon admit. Most of our members in this level of care are designated seriously mentally ill, and so they are also assigned to an outpatient health home. And those health homes are required to have staffings with the BHRF provider and the member at a minimum of every 30 days so that they can appropriately coordinate care and make sure member can make all appointments and to continue that discharge planning piece that Access requires. This is a setting where treatment is considered 24 hours a day, 7 days a week. I see the question from Rachel, what is a staffing? That's a great question. That's when those involved in the member's care get together to discuss their care and coordinate any care that could involve talking about their current functioning, if they're needing any med adjustments, if they need to see any providers or specialty providers, and to discuss their progress towards their treatment goals and any sort of barriers to stepping down at that point. So those are often things discussed during a staffing. It's primarily the member, the BHRF provider, and the health home has their assigned case manager or somebody from the health home to be a part of that. And of course, if the member has a guardian, they're a part of that as well. So part of the treatment is that members must participate in individual and group therapy offered in the BHRF. This treatment does include help with daily living skills, medication management, coping skills, relapse prevention, and substance use if they're in a co-BHRF. Sometimes these groups could be offsite. Oftentimes we're trying to help members be successful in learning independent skills. So they may be offsite learning vocational skills by, the whole BHRF is out doing volunteer work in the community, or they might be at a grocery store learning how to appropriately buy groceries, especially those that may fit their nutrition scale. We also have members receiving treatment in the BHRF. They're not coming and going or going to their health home for groups. They do need to participate in the programming in the BHRF. They also can't participate in day programs, jobs, or in-person school in this level of care, because then they wouldn't be there to benefit from the BHRF program itself. And then members, I saw there was a specific question about members' treatment through medical providers. So the members would continue to receive any psychiatric care from their behavioral health medical provider over at the health home. And of course, continue to go to any specialty providers that have been identified that they need to see. So that is one thing that the health home is responsible for staffing and coordinating with the BHRF team as well, to make sure that the member can get to any appointments and that they're all coordinated. And the next slide.
Hey, Elizabeth, I see Lori Goldstein has her hand up.
Yes.
Lori, you had a question?
My question is, member must participate in individual and group therapy. If someone with whatever condition they have is declining, they're not improving, or maybe they're maintaining. If they're trying to participate, is that good enough, or must they be showing progress?
That's a great question. Yeah, we're looking at this from a clinical lens, so more so that they're showing up to the treatment itself. We do have members that, may only last 5 minutes in an individual therapy session, but just the effort that it took to go to that, we consider the participation. Attendance is still considered participation. What we're more so looking at is to ensure that the member is engaging in that treatment. And I mean, for example, not isolating in their room and skipping out on that participation. But great question. And yes, we're looking at the attendance, and we also speak with providers about progress. As I mentioned before, a member may only be able to last 5 minutes in an individual therapy session, but then 60 days from now, they may be able to do 10 minutes. And so we're looking at every level of that progress that the member is not only putting the effort forward to make, but what that looks like in terms of their treatment too.
If that person is so depressed and ill that they're not participating and they are tending to isolate, where do they go next if the BRF is not the right place for them?
Yeah, that's a great question too. So that would be up to the health home to come up with a more appropriate setting. That's where they're staffing with the BHRF provider and trying to coordinate the most appropriate level of care for the member. So if the member is not wanting to be in a BHRF or engage in that treatment, oftentimes they'll, speak with the member about what they are willing to do or how we can best assist them at where they're at.
But if where they're at is they're simply over time in multiple BRFs, very ill, very, they just don't participate very much, and their families are told, well, they really need a higher level of care, where do they go?
If they're needing a higher level of care, the next level up is inpatient. So they might go there for stabilization. If their needs are more medical in nature, we may suggest or recommend they apply for Altex or look at another setting that may best address their needs. So they are expected to participate in a BHRF because it's treatment.
That's what he's trying to ask her. Right.
I see you all's questions in the chat. So once she gets through Dick's, I'll go through and see them. I was trying to type that just in right now.
So essentially, it will be up to the health home to staff what that most appropriate level of care is, and then apply for that. I did see Dr. Chern's message about members going on pass to be with their families. Yes, that's something that Access does allow, and of course, Mercy Care supports as well. We think it's absolutely wonderful when members do have family to support them, especially in a high acuity setting such as a BHRF, and absolutely encourage members to be able to interact with their families and natural supports in the community outside of the BHRF as well.
And then there's a question in regards to, can you speak to BHRF eligibility, especially around being titled and non-titled?
Absolutely. Unfortunately, BHRF is not a benefit for non-Title 19 members. This is a Title 19 benefit per Access. However, we do have some providers who have grant funding. And so while that is a limited basis, we are able to assist some non-Title 19 members in a BHRF in order, because those funds are so limited from the federal grants. We do have a specific amount of days that they can be in a BHRF, which is 180. So that gives them 6 months to try and learn some of these skills and work on discharge planning to hopefully be successful in their next level of care. But for Title 19, the eligibility for BHRF is based on medical necessity criteria. But for Title 19, they have that benefit. And for non-Title 19, we're still reviewing for the same medical necessity criteria, but there's just limited capacity for that population.
Yeah, and I think what Elizabeth is getting to that point is, so it gets to what codes are covered by titled funding versus non-titled funding. So BHRF, the service portion, is a titled benefit, whereas the room and board is a non-titled state-only benefit. What can be leveraged is the federal grants. So either the substance abuse block grants, and those are for individuals that have a substance use diagnosis, and or the mental health block grants, which can cover children and adults. Children have to have an SED, so serious emotional determination, that now goes through Solari, and then typically an adult with an SMI designation. And as she mentioned, we work with providers to do some contracting so that they can receive that as a covered service, but they still go through the prior authorization process. I think this is kind of similar. So how does somebody with GIMSA qualify for a BHRF?
Yeah, and that's a great question too. Typically, we see two different levels of a BHRF app for somebody who is GMH. One usually is that they're too high functioning for the needs of a BHRF, but the other is that they really do meet that need. And oftentimes once they admit to a BHRF, they'll be reviewed for potentially SMI status. So oftentimes we will see applications we review as normal. It's the same criteria for the medical necessity, which I've referenced in the next couple of slides. But we're still reviewing that, and it's the same process as for SMI.
Another question in regards to that, what kind of vocational training is provided?
It depends on the BHRF provider, but many of our providers will have vocational training in their setting. We do have a few providers that partner with community service needs to, we just had one BHRF take all of their members to plant flowers in the community and kind of teaching them some of those vocational skills. And so activities such as that, or other groups within the BHRF.
Okay, it looks like there's, okay, so I'm trying to keep track here on clinical. So I did respond, Jim says, so general mental health, substance use, that's under the access, complete care contract covering children and adults. It is an integrated contract. And then there are some questions, maybe if you want to walk through a little bit on the family passes.
Yeah.
So Dr. Churn had reported clarify if patients can go out on a pass with their family. And then Carrie asked a question in regards to understanding them they can leave one time. So just the parameters. So what are the parameters around them being able to do the family pass?
Yeah, great question. There are no parameters from Mercy Care at this time. We anticipate that Access will revise their guidelines surrounding this. I think this has been a pretty common question. So we're waiting to see if any exist. It will depend on the provider and making sure that you've added those leaves to the member's treatment plan. So you're specifically documenting what clinical benefit the member receives from those passes. And then that you are able to coordinate with the BHRF to go out on a pass. But there is no guideline from Mercy Care at this time. So the 1 time a week for 4 hours is no longer in place.
To do a little catch up. So Rachel had a question in regards to somebody that's in a BHRF, non-titled, what options do they have for a longer stay? I mean, my thought, Rachel, if you're comfortable, is probably maybe we can, if you want to send along the information, we can talk through the specifics of what's going on with that individual, if that works for you. You can send them to me and I can work with Elizabeth and or the clinical team on that. But that would, my assumption would be we'd want to talk through the staffing and kind of what that looks like.
So is there might be other funding sources if it was medically necessary. Is that the case? Or it's like a hard stop, they need to discharge and we gotta, get them somewhere with an ACT team. I mean, we're in a great situation now. I just know it's coming to an end because she's non-Title 19. So this keeps me up at night.
Yeah, totally understand. And I think that's where I think would be helpful, maybe sending the kind of details and, with the release, we can talk through the specifics of kind of what that looks like. The funding's based on availability of funding, but definitely want to be able to have a conversation so that there's planning in place.
Mm-hmm. And Flex Care is not covered either. So like even the next step down,
right,
we have issues. So
yep.
Anyway, okay.
Yeah, and then Rachel, I think you have my email, right?
Yep, we're good.
Okay. All right, I think I captured all the questions in the chat. Wanted to make sure that, Vanessa, what clinical consideration would it if the client is not progressing at a BAFRH going backwards is detrimental? I'm not, maybe Vanessa, do you want to come mute or Elizabeth, did you get that question?
Yes, basically I'm asking, what if the client at the BHRF is kind of coasting and, maybe then regressing and then coasting and then maybe making a baby step forward and a baby step backwards but the step backwards would be to go inpatient and that would be detrimental to the client.
Yeah, this actually is a really great question and brings me to this slide. So I'll kind of talk about that within this context too. I mean, these are the considerations we're going through with BHRF providers a minimum of every 60 days. So we're talking about these key points for, members' ability to remain in a BHRF. So we're really looking to see, are they truly requiring 24-hour level of care at this point, which would include overnight behaviors, them being physically present at the 24-hour BHRF. Are they participating in treatment? As we discussed before, attendance counts, we're just looking that they're making that effort and engaging in the care within the home. And are they making progress towards their treatment goals, which is a huge component as to whether or not they're really benefiting from a BHRF. So we're just looking to make sure that they're learning those skills and becoming more independent with ADLs, ILSs, and learning their meds and when to take them and why they take them. If they're not really benefiting from this level of care, that's something that we review to kind of consider more appropriate options. We also look and see if they're if they're psychiatrically stable enough to benefit from BHRF. Sometimes they may have more acute symptoms or a trigger that may increase their symptoms, and looking to make sure the health home is coordinating their care and monitoring their medication.
I called her earlier to get to you.
Any meds to help them be successful in this level of care. Also looking that they have an appropriate discharge plan. Even if flex care is an option, it's not always in the member's best interest, or it may not be some level of care that they potentially could be successful in. So we're looking to ensure that those conversations are around more appropriate discharge options. And really, what are those barriers to stepping down? So what is preventing them from being successful at the next level of care? And can they be safely treated at the next level of care? So if a member is kind of remaining, I think you said coasting in a BHRF, or maybe they're regressing, that's something that we want to take a look at too. What is the BHRF doing to help them progress towards their treatment goals if they're not really meeting those goals? Is there a concern in the current location if they're regressing back and needing inpatient level of care? And honestly, sometimes we see a lot of regression when members are in this level of care for too long, when they've met those goals and they're ready for step down, but that step down to flex care is taking too long. We do see that they tend to regress back a little bit as well, without having that opportunity to be successful at a lower level of care.
And I see Frances has her hand up. Frances, you have a question? Oh, if you're talking, Frances, we can't hear you.
You're on mute, Frances.
I'm so sorry. So my son's birth does say only 4 hours. So how do I get them to know that Mercy Care says it can be longer?
They are well aware, if they're contracted with us, they're well aware that we don't have that stipulation. If there is any sort of a Blythe, I believe since early December.
Yeah. Frances,
So
if you want to send us what your provider is, we can follow up with them.
Okay, thank you, Blythe. I
Absolutely.
appreciate that. Okay, and then I have one other question for you. So my son, I don't know what the appropriate actions would be for him. He does have anosognosia, and he's on an extremely large amount of medication, but it's showing there's nothing in his system. Perhaps because he is such a fast metabolizer. What would be appropriate
That
to
almost
happen?
seems that almost seems like it's a clinical question towards the clinical team versus.
Okay, and I have brought that up. I was just wondering what the appropriate actions would be, because they cannot bring it up. They're having difficulties with it on that part. So if there's absolutely no way of bringing it up, I don't know.
Yeah, Frances, I would check with the clinical team, definitely raise that and ask them that question. And if you're not getting a response from them, you know, I know when I come on this call, I feel a bit like a broken record, but you can call the family line and I can repost that through our grievance and appeal, or you can always call the grievance and appeal that can also follow up with that concern, as well as do any quality of care if that's there.
Okay, and then just one last real quick question. So our birth from 8 to 8 gives them a cigarette break. Are they allowed to do that? 13 breaks of cigarettes a day?
That's not something that Mercy Care regulates.
Okay, okay,
Yeah.
okay, thank you. That was all.
They're able to set their own rules and policies. We are aware that some BHRFs have more lenient smoking times and others are more strict, but that's not something that we oversee that particular part. It just varies on the provider themselves.
Thank you so very much. That was all. Thank you.
Absolutely.
Yeah, and I
Hey,
see.
Francis,
Oh, sorry.
one thing, I just want to let you know that we do have a speaker, Dr. Stephen Curry from Banner Health, that will be, oops. So someone should mute.
I think it's me, and I'm trying to mute me again. I'm sorry. The house I'm in is just so noisy. All right, I got to get out. I am so sorry. Okay, yeah.
But what I was going to say is that he will talk about genetics and medication and interaction. And, you know, if they're having such a hard time getting them on a therapeutic level, they may
Yes.
have to, you know, maybe they'll have to run a test and see if his genetic type is just not good with that medication that they're trying to give to him.
Oh, when is
Thank-
that, Lori?
Thank you.
I think it'll be August or September. I'm working with
sounds
Dr.
great.
Stephen. Okay.
Thank you.
And I see, Vanessa, you have your hand up.
Yes, I just wanted to kind of circle back to, you know, I heard you speak about, you know, sometimes being in the BHRF for too long is part of the problem, but that's not what I'm observing. I'm observing that, you know, this person is not, he's not progressing with his, you know, his ADLs and his ILSs. And there's, in the monthly staffing, you know, for some time, there's been that consideration because the BHRF is aware that Mercy Care wants the client to be ready to step down, and that there's some pressure that maybe they're failing the client if they're not preparing the client to step down. But the client is, you know, definitely has anosognosia, but is not progressing, just is not that engaged, and, you know, doesn't think they're ill. And, you know, their ADLs have actually gone backwards since August. And so that's my concern, that the BHRF will at some point feel like they're forced to say the person needs to go inpatient because they're not progressing at the BHRF, but going back inpatient isn't necessarily going to help them progress either. So
Yeah,
I'm
and I
just,
think, no, and I appreciate that feedback, Vanessa. And I think this is where, you know, I think the clinical team discussion, and, you know, Elizabeth, jump in here. I don't want to speak for you or Daniel, but that's where, like, from our team is really getting information from the provider as well as the clinical team. And if you all as guardians or designated representatives and or participants of the clinical team talking through that, right? Like, where are your concerns? You know, does there need to be some difference in the intervention and that type of stuff? And really that's that value of that monthly staffing. And I think I want to stress that though you can have the staffing is monthly, you can ask for a staffing at any time, right? Like, so to be able to say, hey, there's been a change, or I think it's important for us to get together and have that treatment plan review, clinical assessment of what's going on.
well, and so I just want to speak to that because we have monthly staff meetings. Occasionally, you know, it's missed and I have to push. And so it maybe takes it 5 weeks or 6 weeks, but that conversation is happening.
Okay.
but nothing is changing. And for example, in the treatment plan states that the client will receive CBT therapy and really, participate in counseling one-on-one and mindfulness, etc., for 60 minutes, when at the same time, they're acknowledging that the client won't participate or will only engage for 5 minutes, or for group, to up to 10, 15 minutes. So why does it say in the treatment plan that he's going to get CBT and he's going to do all this stuff when, he's not?
So Vanessa, I think it would be great if you're comfortable again, emailing myself with some specifics so that we can do some follow-up on the BHRF, our acronyms, as well as clinical teams, so that I can get some more on your concerns and where we can support.
Thank you. Can you put your email in the box? I appreciate that. Thank you very much.
Yeah.
And I just have these two slides left, and it's really just taken directly from our criteria from Axis. You're able to Google this. It's Axis AMPM 320V. And this is outlined in there on what services the BHRF is to provide for members in their care. It includes group and individual therapy, skills training and development, including independent living skills, community retention skill building, and social communication skills, as well as behavioral health prevention and/or promotion education and medication training and support. This all encompasses symptom management, health and wellness education, medication education and self-administration skills, relapse prevention, psychoeducational skills, the vocational skills we discussed earlier, and substance use disorder treatment, including groups and counseling. And on the next slide, Blythe, it outlines all the services for hands-on care. Oops, it's not showing. There we go. Thank you.
I'm trying to do too many things. I'm sorry, Elizabeth.
My apologies. This outlines all the personal care services that can be offered within a BHRF. So we do have many services for hands-on care that can be under a BHRF that is specifically licensed to provide PCS services. So again, you won't find these providers with the ability to provide these services unless they have a specific PCS licensure in addition to their BHRF licensure. So we do have some facilities that are able to accommodate members with those physical health needs. If it exceeds the needs that are outlined here, typically they would require a higher level of care. And the only other thing to remember about PCS BHRF is that this still is a behavioral health residential facility. So in order to meet criteria to remain there, they have to have primary behavioral health symptoms. That this is not a physical health level of care. It's primary, the behavioral health. So once their behavioral health symptoms are no longer meeting that criteria, they would need to discharge to a more appropriate level of care. They couldn't remain just on needing personal care services alone. But I really hope that a lot of this information helped, and I think we might have some more questions in the chat that I'd be happy to stay on and answer to.
We do. I see, Crystal, you have your hand up. So if you want to go, and then next I see Lori, and then Dr. Churn. I'll see if I can respond in the chat. So Crystal?
Yeah, can you hear me?
Yes.
Okay. I don't know if it's coming through the phone or the thing, but what I wanted to, the only thing I kind of had a comment or what I wanted to say was that I worked at the state hospital for 30 years. And there's still some of the people that never, like, if we're going to treat people in the community, there's going to be people that, because of their negative symptoms of schizophrenia, are never going to be able to meet the criteria to remain in a BHRF. They need something more like if you're not going to have a state hospital, then there has to be some kind of permanent housing. Or housing with supervised housing, like what they do in DDD. And so I'm wondering if Mercy Care has ever looked into that, because you have people that just are never gonna go up or down enough to be either independent or they're persistently and acutely disabled, right? Or gravely disabled. Does that make sense?
I think I heard
Absolutely.
your question, Crystal. You were a little muddled, but if I heard it right, your question was looking at long-term housing that has supports.
Correct.
Yeah, so I think that that's a little bit, and Elizabeth, if I can jump in here and then you can add in here. So I think as Dick had mentioned earlier, community living program was addressed specifically for that. So that is where individuals sign leases. They can be apartments or two project-based leases. All access housing for Medicaid is now managed through ABC. They have a direct contract for that. And then you can get services. And so those vary a little bit. And so that's
So
Medicaid
what's
supported
ABC?
housing.
Okay, so what's ABC? Because these people, they're persistently and acutely disabled, so they can't live independently. So what does that mean? Like you can't put them in an apartment house.
So
Right?
in a couple, right. So I think that's, so if you're thinking like the BHRF, that's like a prior auth service. If somebody's living in their own home. So one of the reasons like way back, the community living was designed and, it kind of gets to this model, which is similar. I know ACIM knows it well, where they can get in-home support. So it really depends what that person needs. I think that that's the
Okay.
balance that typically tries
So
to
they
come to
offer,
play.
so they would
With
offer
some,
24, they would offer 24/7 support with like an assistant in the house with them.
in some cases that has been offered, or there's been therapeutic foster care. I know that there's been other discussions in the sense of secured residential. That's probably for a whole nother topic of discussion in regards to the legislation around that, which is a different population. But yeah, there are situations that have that. The regional behavioral health authorities no longer manage the access Medicaid housing vouchers anymore. That's split, but the services, the Medicaid services remain with the health plans.
And Blythe, you covered everything I was going to speak on too. So that's perfect.
Yeah, but also that's still, I mean, again, I'd like to have more communication and conversation about that, because if we're really going to treat the seriously mentally ill, the ones that we took out of the hospital that we don't want in the hospital again, that they want to treat in the community, then those services we're missing. And I think Dick was trying to get to this as well, is that there's no in-between level of care that could be provided in housing, like a little bit higher level of care that wouldn't quite be a hospital, but would be providing care for our persistently and acutely disabled as well as gravely disabled. So
we're losing you,
I'm
Crystal.
losing you a little bit, Crystal, but I do think, I think that, when we've had conversations with access and kind of what that continuum looks like from what's like a covered service with access versus what is Medicaid covered services and long-term that's not based on medical necessity. So definitely, open as Mercy Care to listen to the thoughts of what you all are seeing and the needs in the community. And think about what those options may be.
Okay, thank you.
So my question was about this personal care service homes. You mentioned that they need to have a additional license to be able to do hands-on. How many, I mean, not number, but percentage, do 1%, 10%, 50% of our births have this, or is it a real small number that have that dual license?
It is a smaller number. I apologize because I don't know a specific percent. But this is a smaller need in terms of all of our BHRF population that's in this level of care. But there are several. It's not that we just have one provider that can do this. you know, I don't know off the top of my head how many are licensed with us, but I do know that we have many to choose from, and it's just not it's not standard across all BHRFs. So I wanted to just make sure that everyone understood that even if you're in a BHRF, not everyone will be able to provide these specific services. I can try and get a percent to Blythe and get that out to you, but it is smaller.
I have a quick question. The issue that I run into quite often is submitting a BHRF, and to be honest with you, it takes an act of God to get that approved. You know, and I complete peer-to-peers, and they, I mean, I'm not being heard, and I'm running into this barrier of just pure refusal. I was successful recently in overturning a decision for a BHRF, but that was the reason. I mean, the reason was because all text was pending. But yeah, I have a very difficult time getting those approved. So I'm not quite sure what that is all.
Thank you for you know, sharing that. It's something that my team has done extensive education with all health homes on. And we do have our team lead, Heather, goes out to the health homes in person, and she also does virtual trainings to help case managers and of course the physicians assigned to our members, helping them understand what it is that we need and what it is that we're looking for in the BHRF app clinically, so that we can approve it.
Right,
and
right,
that's
right.
been
The wandering behaviors, the you know, all that stuff, everything is accordingly to the criteria. However, you know, it's really difficult to get those approved. So, and how can we expedite getting a peer-to-peer completed? Because you know, it takes about 30 to 40 minutes to get a hold of somebody to just schedule that.
Blythe, that might be something that we can look at if
Yeah,
there's
we can
any
take
sort
that
of
back
lag in being
internally.
able to call in. Yeah.
Thank you for that feedback. So we'll look at that internally, and then with some of the follow-up, we can get that out. Is it Jana? Is that how you say your first name?
Janina.
Janina.
Yes.
I just wanted to comment on Dr. Chern's question about, you know, making sure there's no retaliation. This is something that is the most important to myself and my team, is the safety of our members in this level of care. We work very hard to minimize any risk for them. But if there is a fear of retaliation, or if there is retaliation happening, we work to expedite them to be able to transfer to a different facility and ensure that they're at least safe and able to try and make progress in this level of care. We don't want someone to remain in a situation that isn't healthy or has them in any sort of fear. So just wanted to reiterate that that's really important to us here.
Agree. And I see 2 hands up, and I apologize. I'm not quite sure what time the session goes to. I had 5.
Yeah.
I have to get my
I was
mom
gonna
at 5:30. So I
Yeah.
want to be
I mean,
mindful, not leaving her somewhere. I
This
see
is-
Allison and Rachel.
And then we'll cut it off. I mean, typically it doesn't go this long, but as you can see, there's a real appetite to try to understand the system, what the rules are, what the limits are.
It's great. We appreciate the feedback. I just want to be mindful that Allison, I'm not just like peace out and then I'm gone. My mom's like, where are you?
Yeah. Okay, we'll have the last 2 questions because you guys have been generous with your time.
All right, Allison, I saw your hand up
Sweetie,
first.
I'm gonna go to the room.
Thank you so much, Blythe.
You sure you're gonna be able to tolerate him?
I just want to
I want to provide an additional perspective to what Janina was just speaking to in terms of getting the applications approved. So I became my brother's legal guardian about a year ago, and he is non-Title 19. And when I signed on to this adventure, it has been an adventure. I really expected to join a team of caring and compassionate healthcare providers, and that wasn't necessarily the case. And you know, instead of support, I really found myself mired in a system that did everything to keep my brother from accessing services. On 2 separate occasions, a Mercy Care representative during a staffing instructed the outpatient team at Copa Health to submit a BHRF application with PCS. And that application was denied despite documentation of need, including a diagnosis of severe cognitive impairment. Mercy Care maintained there wasn't enough evidence. Shortly thereafter, I was notified that my brother would be discharged with or without a secure housing plan. My attorney stepped in and my brother was moved from CBI to Mountain Vista for additional evaluation and treatment, and it just went on. A second BHRF application was submitted. It was approved, it was celebrated, only to find out a few days later that the approval was a mistake. The clinical team at Copa Health did everything to reach out to Mercy Care for help, and the phone calls were denied. My attorney reached out to the chief program coordinator at Mercy Care. No silence, no return of phone calls. It fell through. I mean, it just never happened. And for me, I wanted my brother to get into a BHRF long enough so that I could get him the medical diagnoses of dementia so I could get him approved for Altex. And I couldn't even do that. I requested staffings. They were denied by, I was told that when he was at Mountain View, he couldn't, they wouldn't do a staffing because he was non-Title 19. It was just every step there was a hurdle. And it was hard. It took its toll. I just have to say. And in the end, I was able to find him some housing and was able to get him approved for Altex. But wow, what a journey. And I really wanted Mercy Care to be part of the team, the supportive team, and I just didn't feel like that was there. So anyways, thank you for letting me say my piece.
No, and thank you for letting us know that. That's definitely not the experience that we want you to have. You know, I would love to be able to kind of go back, if you're comfortable to share your loved one's name, to just go back and look at that process so that we can consider ways to improve based on taking a closer look on what you just provided.
Offline. I can email. I'm thinking your email went into the chat.
Okay, yeah, you can email me that. And then Rachel, I see your hand up.
Yep. So there's a big problem happening right now where individuals are at Valleywise and they've been placed on COT. They've been clinically indicated for a BHRF, and to free up a bed, they're transferred out to one of the 3 hospitals that Valleywise can send them to. And they never get the BHRF. They are instead being discharged to the street because Mercy Care will do a utilization review or what have you, and there's no birth bed available. And it's becoming particularly dangerous because aging caregivers, you know, mothers, parents in their 60s, 70s, even 80s are being given an option: take in your sick kid or they're going to be in a shelter. And I just want you to be alerted that this is happening. And I don't know if it's because of a wait list of BHRFs or what's going on, but it's a real problem. And I'm worried that one of these caregivers is going to get hurt. That's all.
Well,
Yeah,
thank you,
thank
Rachel, for
Thank
giving us
you.
that information. And Elizabeth, I saw you shaking your head as well. If a BHRF application was put in at one hospital, that process would still continue through. So again, any specifics that you can provide me that I can work with the team internally is very helpful to us.
Okay, I'll send you
Okay,
some.
and
Thank you.
Okay,
Okay,
thank you.
with that, I know you have to leave.
I
If you
do.
can send me your wrapped up slides, that'd be great, and I'll get them posted. Again, thanks again. There's just so much appetite for knowledge, but thank you guys. You're willing, if anyone can stay for the family portion to talk about specifics and what's going on. Some of that has already started, but I know you have to leave. So I'm going to stop the recording now. And anyone that wants to stay can stay.